Hello, everyone, and thank you for joining us on this webinar. The topic is viral respiratory tract infections, superinfections. My name is Souha Kanj. I'm professor of medicine at the American University of Beirut Medical Center, and it is my pleasure to be moderating this webinar. This webinar is on behalf of the two societies, the International Society of Antimicrobial Chemotherapy, which was founded in 1961. ISAC is a federation of affiliated member societies, which aims to increase the knowledge of antimicrobial chemotherapy and combat antimicrobial resistance around the world. ISAC currently has a worldwide membership composed of 97 national and regional societies, which in turn have over 60,000 individual members. It hosts the International Congress of Antimicrobial Chemotherapy every second year, and the next ICC will be held in Istanbul in November 2024. Please mark your calendars. Also, this webinar is on behalf of APUA. APUA is the Alliance for the Prudent Use of Antibiotics. APUA was founded in 1981 by Professor Stuart Levy, a pioneer in the field of antibiotics. APUA was one of the first organizations dedicated to promoting antibiotic use and curbing antimicrobial resistance. APUA merged with ISAC in 2019 when Professor Levy retired. The continuing mission of APUA is to maximize the effectiveness of antimicrobial treatment by promoting appropriate antimicrobial use and containing drug resistance. As you know, today's webinar is on viral respiratory infections and what are the superinfections that we have seen. Superinfections has been one of the hottest topics during the first waves of COVID-19, although it was rapidly demonstrated that co-infections were initially rare during the first days, but we learned as the pandemic progressed that superinfection with bacteria as well as fungal infections became a major issue in COVID-19 infected patients. And more recently, there has been a dramatic increase in group A strep infections, and really for reasons that still remain not very clear and that hopefully we'll learn about from one of our guest speakers. I think without any further delays, I'd like to start by introducing the first speaker for our webinar, and that is Professor Nina van Sorge. She's going to talk to us about Group A streptococcal infections. Nina is how people call her. She's the director of the Netherlands Reference Laboratory for Bacterial Meningitis at Amsterdam University Medical Center. Her lab combines fundamental and molecular epidemiological research with the hope to improve existing, but also identify new strategies to prevent and treat bacterial infections. Her experimental work specifically focuses on the human pathogens Staphylococcus aureus, as well as Group A strep or Strep pyogenes, for which she is co-inventor on a patent on Group A vaccine. In addition, she coordinates and leads the activity of the National Reference Lab, which performs the national bacteriological surveillance for invasive bacterial infections, including, of course, invasive Group A strep infections. Professor Nina, the microphone is yours. Thank you.
Thank you very much for this very kind introduction and, of course, for the invitation to share some of our insights on what we have observed and learned from the current outbreak of Group A streptococcal infections in the Netherlands. As mentioned already in the introduction, I have one disclosure, which I also put on a slide, which is the fact that I'm a co-inventor on a patent on Strep A vaccine development. So let's start at the beginning. Streptococcus pyogenes, to the majority of people known as Group A streptococcus or GAS, a gram-positive chain-forming coccus, human-restricted, and a common colonizer of the throat and also on the skin. If individuals are infected with group A streptococcus, there are certain diagnostic characteristics from this bacterium that help us to identify it. So it's hemolytic on blood agar plates, and it has this specific agglutination in the streptax agglutination assay with streptax A, which is a very characteristic feature and also convenient for rapid assay diagnostics. Finally, and this is even at a more detailed level, looking at diversity of group A strep strains, and in the context of epidemiology, we also look at sequence diversity of the so-called EMM gene, which encodes a protein on the surface of group A streptococcus, highlighted here in green in this electron micrograph. And in this way, we now know that there is a large diversity of group A strep isolates by the more than 200 different EMM types and subtypes that we have identified. So looking at the clinical spectrum of disease this single bacterium can cause, this is actually very, very diverse. So most of the infections are superficial infections, such as impetigo and strep throat. Often these are self-limiting, don't need any treatment. The problem is, of course, in the invasive infections also that we are currently seeing outbreaks of. And these include also a long list of different clinical entities, such as necrotizing fasciitis, purple sepsis fever, meningitis, and so on. In addition, in the low and middle income countries, a large burden of disease caused by this single bacterium are the post-infectious immune sequelae, which can result in rheumatic heart disease and chronic renal failure. If we combine all these different clinical manifestations that group A strep can cause, this causes an estimated 600 million infections and nearly 500,000 deaths every year globally. And unfortunately, we do not have vaccines available to reduce this global disease burden. In addition to this already high disease burden, group A streptococcus is notorious for its epidemic outbreaks. Probably the first description of such an outbreak, at least it's attributed to Hippocrates, which described an outbreak of erysipelas. A little bit more recent is actually the notorious outbreaks of nosocomial infections on maternity wards. At the time, of course, it wasn't known that this had a contagious origin, and it was only through the pioneering work of Ignaz Semmelweis that it was recognized as a contagious cause, and he introduced hand hygiene as a way to prevent further spread on these maternity wards. Even more recent, in the 1980s, after a period of reasonable, quiet or low incidence of invasive group A strep disease, in the 1980s, we saw again a global resurgence of invasive disease manifestations by this pathogen, and this was finally attributed to genetic changes that had resulted in the emergence of a new, more virulent clone. Overall, needless to say, we actually need to keep track of this pathogen through long-term surveillance to monitor especially the changes that we observe in epidemiology. So what ways do we have to track epidemiology of invasive group A strep infections? Many countries have statutory notifications in place. So these are notifications that depend on a specific clinical picture, and usually this also needs to confirm the presence of group A strep either from culture or molecular methods. Unfortunately, these notifications are often restricted to a limited number of clinical entities, and that is because these notifications are followed up very closely, for example, through chemoprophylaxis to close contacts or household contacts, or in case of suspicion of a cluster, for example, of maternal sepsis, we need to see if there's maybe a common source that spreads the infection. But as I already mentioned, the range of invasive infections is very broad. So by limiting the statutory notifications, we only see the tip of the iceberg of the total burden of disease. So we need another method or another data source to get a better overview of the total burden of disease. And one way to do this is through laboratory-based surveillance. So this is not based on a specific clinical manifestation, but instead based on the culture or molecular detection of group A streptococcus in a normally sterile site. So this is one of the things that we do in the Netherlands. Very specifically, we have national statutory notifications for the 3 clinical entities listed here. And since 2019, right before the start of the COVID pandemic, we introduced molecular bacteriological surveillance for invasive group A streptococcal infections, which involves EMM typing and whole genome sequencing in case of suspicions of clusters. We also have in place, but I will not discuss that today, a primary healthcare network for the surveillance of non-invasive diseases caused by group A streptococcus. So from these notifications, if we look at historic incidences or occurrences of invasive group A strep infections, and this concerns all age groups, you can see that from the start of 2016 all the way up to January 2022, these manifestations usually follow a seasonal pattern, which is very much linked to respiratory infections such as influenza, but also chickenpox in children, which are a risk factor to develop these diseases. And a second thing that you will note is that during the COVID restrictions, we had a very much lower incidence of these types of severe infections. However, immediately after lifting all the COVID-19 related restrictions, we saw quite a steep increase in the number of cases, these notifiable cases in the Netherlands, which even preceded the numbers pre-pandemic. And what was especially alarming was the fact that the number of cases was very high in infants and young children 0 to 5 years of age. So that is depicted in this graph. Again, we spent January 2016 until January 2023. And you can see that the number of cases in 2022 was really high compared to all the preceding years. Overall, the notifications accumulated to 42 in total for this age group. 9 of these infants and young children died, 7 had preceding chickenpox, and 2 had a tonsillectomy. And just to show you that this is probably, again, the tip of the iceberg, there's also been a survey performed by a pediatrician of 7 Dutch hospitals in this time frame, July 21 until June 22. And already in these 7 hospitals, they identified 49 cases of IGAS in children. And again, you can see here that respiratory or viral infections are often found preceding or co-occurring with these severe invasive group A strep infections. So the Netherlands was not the only country that was observing these increases in invasive group A strep infections. So also the UK notified this increase, and this finally resulted in 2 press releases from ECDC as well as the World Health Organization to alert countries that this could potentially be going on also in their country. So we now have also data available from molecular typing of invasive group A strep isolates. And this is performed in Amsterdam through the Netherlands Reference Laboratory for Bacterial Meningitis. We have already been looking at group A streptococcus, but only in the context of meningitis from 1975, where we do this in a much broader context. But from 2019, the infrastructure of the Bacterial Meningitis Reference Laboratory was used to also set up prospective surveillance for invasive group A streptococcal infections. And we started off actually rather small by covering 28% of the population through 9 sentinel laboratories. But when this increase started in spring last year, we asked actually all Dutch hospitals to submit to us isolates from normally sterile sites for further typing. So we now actually have national coverage of all IGAS or nearly all IGAS cases. And the way we type these isolates is through sequencing 180 base pairs of the EMM gene, which is something that is done across the globe to make it comparable between countries. So this prospective surveillance was actually quite successful, as you can see here. So I plotted here the number of isolates that we received in the reference laboratory. So before 2019, these were just isolates from patients with meningitis, so just a handful every year. And when we started the prospective surveillance, you can see that the numbers are steeply increasing, and especially in 2022 and 2023, this has been a huge increase in the number of isolates that we are receiving and typing. Interestingly, when we look at the different EMM types, you see that there is quite some diversity with 161 EMM subtypes among 3,500 isolates, but it's also clear that there are dominant M types among the patients with invasive group A strep infection. And this is already well known in the field that certain EMM types you probably carry more virulence potential and therefore are more commonly found in patients with invasive group A strep disease. What we also noticed from the data that we collected is that there was a clear shift in the affected, in the age of the affected patients. So what I plotted here is the number of isolates per age of the patient in 2019 versus 2022. And what you can clearly notice is, of course, this peak that appears for the infants and the young children, but also you can see that there is quite an increase in the number of isolates that we received from individuals age 60 plus. One of the things that stood out in the current outbreak is when we looked into the EMM types that were causing these invasive disease manifestations. So this is quite a busy graph, so I'll walk you through it. What is plotted here is per month, the number of isolates or the proportion of isolates that we received, and in the different color, there are different EMM types. And what was very clear towards the end of 2022, which was actually the moment that we saw a lot of adults getting admitted with invasive group A strep infections, but there was this jump in the proportion of EMM 1.0 strains. EMM 1.0 is always dominant in invasive disease, but not to this extent. So here we see it up to 65% of all isolates had this EMM 1 type. If we look at children, ages 0 to 5, here we also see that EMM 1 is actually quite dominant. So this is something that we see across all age groups. If we look at EMM 1 in relation to different clinical manifestations of invasive group A strep infections, that is plotted in this graph. So you can see again the 3 notifiable disease manifestations, and in the different colors you can see the different EMM types that are causing these infections. And what is very clear is that in these different manifestations, especially in necrotizing fasciitis and streptococcal toxic shock syndrome, EMM 1 is very dominant. There also seems to be a bit higher diversity in isolates in the puerperal sepsis fever in patients. Finally, what we noticed, and this is because we had such a long-term surveillance on bacterial meningitis for group A streptococcus, we could actually see that group A strep meningitis had an increased incidence already in 2022, but we see this continuation in 2023. And what was really obvious is that there is a big dominance in patients with group A strep meningitis of this EMM 1 type, as you can see from this graph. So not only do we see a dominance of EMM 1, we also see an increase in clinical manifestations with this EMM type. So what are potential causes for this outbreak and the dominance of this M type? So I will talk a bit for the rest of the presentation on genetic changes in this specific EMM 1 population of group A streptococcus and how this could maybe affect carriage, transmission, or virulence. What is, of course, an obvious one, especially in the context of this webinar, is that the increase that we see in eye gas infections is due to an increase in viral infections that predispose to these manifestations, such as varicella zoster virus and influenza. And this is most likely indeed the case for a certain period of time that the outbreak was going on. But even now that these viral infections have subsided, we still see quite a high incidence of eye gas infections. So this is not the complete story. And finally, one thing that we are considering but haven't been able to address experimentally is this thought that maybe due to all the COVID restrictions and less transmission of the bacteria between individuals, that this may have resulted in lower population immunity to group A streptococcus, and therefore an increased pool of susceptible individuals. So I'll focus the rest of my talk on these genetic changes that may explain at least part of the current outbreak. So one of the things that we had access to was group A strep isolates from carriers that do not have any disease, so what we call asymptomatic carriers of group A streptococcus. And we had information from 3 different, or actually 5 different studies in different time periods that are plotted here. And what we could see in these carriage isolates is that EMM1 comprises approximately 10 to maybe 15% of these carrier isolates. Fortunately, we were able to perform such a carriage study again from September 2022 until February 2023. And I'm happy to share these data already with you that are depicted here. So this is our new data from a carriage study, where you can again see that EMM1 is actually still quite stable at about 10 to 15%, as what we have seen in previous years. So we actually think that the dominance of EMM1 in invasive group A strep infections that we're currently seeing is not due to a change in carriage of this EMM type. However, what may be going on is that there have been genetic changes to this EMM strain that have resulted in increased virulence. So this has already actually been described back in 2019 by Nicola Linsky in the UK, where they have seen that there was a specific lineage emerging among the EMM1 strains that they called M1 UK. And this strain was characterized by 27 single nucleotide polymorphisms. And these 27 single nucleotide polymorphisms were linked to an increase in scarlet fever and an increase in invasive group A strep infections in the UK. And what they describe is that the change of these 27 SNPs resulted in a 10-fold increased production of an important toxin, SPA. And this SPA is a superantigen, which means that it can activate in an aspecific manner about 20% of the T cell population. And this, of course, can have detrimental effect on the immune responses that we see. And it's one of the contributing factors, for example, to streptococcal toxic shock syndrome. So what about this M1 UK variant in the Netherlands? We had already, we have the capacity to look at this, and you require whole genome sequencing to actually to look at this, because you need to go back to 27 SNPs. So from our retrospective study that we performed between 2009 and 2019, we had 124 EMM1 isolates available, and we determined that 21% of these EMM1 isolates was actually an M1 UK variant. And of these M1 UK variants, 90% was actually from patients with invasive disease, and 10% was from asymptomatic carriers. So it seems to be very dominantly present in patients. We were able to also look very specifically in 2019, the time when our prospective surveillance started. At that point, 15% of the received isolates was of the EMM1 type, and we determined that already 64% of these was M1 UK. And then what happened in 2022? Well, I've shown you already that EMM1 has increased from a presence of 21% to 75%. And by performing whole genome sequencing on just a sample of these EMM1s, we determined that 90% of these were already M1 UK. So there seems to be a clonal replacement of the EMM1 strains with this M1 UK variant, which has higher toxin production and is therefore likely more virulent, causing more invasive disease in perhaps a more susceptible population after all the COVID restrictions. All this together made that in January 2023, there was a response team gathering convened by the National Institute of Health and the Environment, where it was decided that we would expand chemoprophylaxis to household contacts from patients with every eye gas manifestation. So not restricted to just the 2 clinical entities that I mentioned before, but all household members from patients with eye gas would get chemoprophylaxis. Oh, and we will evaluate this actually in 2 weeks' time, how this has turned out. So in conclusion and for the discussion, I hope to have shown you that laboratory-based surveillance of invasive group A strep is actually critical to monitor these changes in epidemiology and especially pinpoint maybe specific reasons for these changes, and that this information can be very valuable to support decisions on changes in public health interventions. And I would like to stress that I think that eye gas surveillance should be more internationally coordinated, because in this way, it is quicker to detect outbreaks. We can develop best practices and align intervention methods across countries, and hopefully identify at-risk populations so that we can very effectively incorporate or implement future vaccines to curb this high burden of disease by this pathogen. And with that, I would like to thank you for your attention. And in blue, I highlighted the people that were involved in this work. Thank you.
Thank you very much, Professor Nina van Sorge. This was really an excellent overview. I think you helped us understand what went on in the past few years with the surge in Group A strep. For the attendees, as you see in the agenda, we have 10 minutes at the end of the program for questions and answers. But also, please feel free to send in your questions on the chat. We will try to address them. I kindly ask the speakers to try to address them on the chat, but hopefully, in addition to that, we'll have time for Q&As at the end of the webinar. Thank you very much. And now, without any further delays, I'd like to introduce our second speaker. It's my pleasure to introduce Professor Anuradha Chowdhary. Professor Anuradha is a professor of medical mycology. She is someone who also has affiliation with the Netherlands, as she did her PhD at Radboud University in the Netherlands. And currently, she's a professor of medical mycology at the Department of Medical Mycology at Vallon Bhai Patel Chest Institute, University of Delhi in India. She is a member of the ISAC Executive Committee, and her research focus on antifungal resistance, molecular typing, and epidemiology of emerging pathogenic fungi. Professor Chowdhary's latest research concerns the understanding of the emergence of multi-drug resistant strains of Candida auris. And as you know, this fungal infection, which has globally emerged now, is one that has caused serious concern and much global spread, including after the COVID-19 pandemic. In addition to her focus on C. auris, Professor Chowdhary also is an expert in the field of emerging resistance in Aspergillus fumigatus to the azoles, as well as studying the ecological niches of Cryptococcus. In this talk, though, she will focus on fungal infections in the intensive care units. Professor Chowdhary, the microphone is yours. Thank you.
Thank you, Dr. Souha, for this introduction, and thank you very much for giving this platform to discuss fungal infections in ICUs, because these are highly neglected field, and thanks to COVID and thanks to several other conditions that fungal infections are now on the forefront. Okay, so before I start my talk, I just like to say Professor Nina explained very well about the role of bacterial pneumonias, bacterial infections in patients with severe viral respiratory infections. But I would like to add that although secondary bacterial pneumonias are highly significant cause of morbidity and mortality in patients with severe respiratory viral infections, but they are not the only pathogens which cause secondary infections. Fungal infections, although the occurrence of fungal infections occurs less frequently as compared to bacterial, but they are always associated with high mortality, and they are a significant cause of morbidity and mortality. With this, first of all, I like to talk about the fungal co-infections which occurred in just an overview of fungal infections which occurred in COVID-19 patients. We are facing this pandemic, and during this pandemic, the majority of infections which occurred were, the number one was mold infection called Aspergillus fumigatus, the causative agent causing aspergillosis, followed by candidemia or bloodstream infection or candidiasis caused by Candida species. And these two infections are highly significant globally. I will also be talking about local regional epidemiology of other countries, but these two infections were reported in high numbers from all over the world. And primarily, if you look at the fungal co-infections risk factors which were associated with these two important diseases in the ICUs, were majority of them was host factors, and specifically the medical procedures which were taking place, which such as intubations, which predispose the lung tissue for fungal colonization, was one of the important risk factors for acquiring these fungal infections. And also the role of corticosteroids has been well established, where majority of these fungal infections, the role of corticosteroids were there because aspergillosis was associated with high dosage of corticosteroids, whereas many studies have focused that candidemia also was associated with corticosteroids use. So also the risk factor, such as chronic pulmonary diseases, these patients had more chances of fungal co-infections, and also antimicrobial therapy played a key role. So these were the overall risk factors which were reported in several series. But coming to this, I will also like to say that only COVID-19 was not the SARS-CoV-2 was not the only virus where fungal co-infections were observed. And this was also very clear when other coronaviruses outbreaks occurred. So one of the example is SARS outbreak, which occurred in Toronto. And here, the study has very systematically planned, and there were 44 deaths during March and July in 2003. And when they conducted autopsies in 20 patients who died in Toronto outbreak, what they observed was 3 cases were co-infections. And among these superinfections or co-infections, 2 most important cases were aspergillus in the lung tissues. And here you see the hyphae, which are dichotomically branching, which shows they are invasive. So these 2 patients were both female patients and had co-infection with the aspergillus. And what was significant was angioinvasion was very prominent in one of the cases. So just to keep you updated, that fungal co-infections existed even before the COVID pandemic. And also it's very well associated influenza, respiratory tract infections, where aspergillosis has been reported and actually has been known as one of the risk factors in these patients. And I've chosen this study because this is a landmark study, which is a retrospective cohort study. It is a multi-center cohort study of adult patients more than 18 years who had severe influenza, and they were admitted to 7 ICUs across Belgium and the Netherlands. And during this study, they spanning from 2009 to 2016, 432 influenza cohort patients were included in the study. And what was remarkable was that overall, 19% of the patient developed invasive pulmonary aspergillosis. And among these 19% patients, the majority of aspergillosis occurred in immunocompromised patients with influenza. 32% of the pulmonary aspergillosis was in immunocompromised patients, like hematological malignancies and others. And also in non-immunocompromised influenza cases, the incidence of aspergillosis was high, about 14%. So this study focused and showed the role of the role of invasive fungal infections, especially aspergillosis, in influenza patients. And also they clearly showed that in influenza cohort with invasive pulmonary aspergillosis, the 90-day mortality was very high, 51%, as compared to cohort without invasive pulmonary aspergillosis. And the important risk factor which were independently associated in influenza cohort was in patients for the development of invasive pulmonary aspergillosis was higher Apache score, male sex, and use of corticosteroids. So this is one of the study which clearly showed that influenza was an independent risk factor for development of invasive pulmonary aspergillosis and was associated with high mortality. So what is there that these fungal infections occurs in damaged lung? So of course, just a brief overview, this is a small pearl, which very clearly highlights that the changes, the damaged lung serve as a premise for these infections, for Aspergillus species especially, to get foothold in the damaged lung. And how does it do it? One of the physiological consequences from viral infections are damaged epithelial damage. And when once this epithelial damage happens, the Aspergillus conidia gain foothold, and also there is a loss of cilia. So and the tight junctions, the leaky airways, all these factors and delayed repair of the lung tissue, all these factors promote the growth of conidia into the hyphae in the damaged lung. And also not only that, there are such many immunological consequences from viral infections, which I have just few I have listed. And these are important because these are the underlying factors which happen in the damaged lung and where the viral infection, where the Aspergillus species especially gains a foothold. And these are the depletion of alveolar macrophages. And also there is a decrease in recruitment of chemokines and cytokines, and also impaired neutrophils due to either the steroid use or due to the reduced activity of NADPH. And all these factors leads invasion of conidia, from conidia to the hyphal forms. Now, in these conditions, when influenza or in COVID-associated pulmonary aspergillosis, what was observed that the traditional risk factors for the development of invasive pulmonary aspergillosis were not present. And these were the initial studies which were undertaken during the early pandemic. And these traditional risk factors were not there. And the gold standard for the diagnosis of invasive pulmonary aspergillosis was always histopathologic evidence of dichotomously branching, means invasive Aspergillus hyphae presence in the tissue. But due to lack of classical risk factors in influenza-associated pulmonary aspergillosis as well as COVID-associated aspergillosis, the diagnostic criteria has to be settled down. So this was one of the defining study which was given by the experts of mycology in the early outbreak, when the aspergillosis outbreaks were happening all over the world. So this consensus statement came out from ECMM. These are the mycological societies and International Society of Human and Animal Mycology. And they also defined although the three categories of probable, proven, and possible aspergillosis. But what they gave the consensus criteria that any one of the factors, either the histopathologic or direct microscopy detection, or culture of the Aspergillus species, or by PCR, any one of these criteria could be used for detection of aspergillosis. And you can see that here it is the different categories of COVID-associated pulmonary aspergillosis definition. But what was more important that ECMM and ISHAM guidelines, what they say is at least one of the mycological criteria should be there, which could be anything, presence of culture positivity or galactomannan, or the presence of qPCR. And also one of the criteria plus is imaging, which is very non-specific in patients with COVID-19. Specifically, pulmonary infiltrate are important. And also one of the clinical factor should be there for which gives a suspicion of pulmonary aspergillosis. And also a large number of patients were observed where not only pulmonary aspergillosis, but tracheobronchitis was observed. But the problem here was that pathology, like you cannot conduct the lung biopsy is difficult in these cases because of the issues of hospital infection prevention issues. It can be transmitted from, it has a lot of exposure to the person who is doing it. So histopathology was not significant, was not important, that if the lung biopsy cannot be conducted, then there were certain other criteria which you could do. And was one of the most important thing which they said that screening, if the patient had one of the cavitary lesions, if the patient has mycological finding, then you start screening these patients with either with serum galactomannan or by LFA, and at least 3 times a week, and screening of these respiratory samples when you have a culture positive, you have a galactomannan positive or PCR positive, then it is a strong indication for the complete checkup, for the complete investigation of suspected aspergillosis. So with this, I just wanted to highlight that the diagnostic criteria was difficult. Diagnosis of aspergillosis was difficult during this time, but still lot of cases were reported in different studies using different criteria. So using this criteria was also used in this one of the French studies, and they came out with a very interesting finding that when there was a direct examination of histopathology tissue or the lung tissue, and also the qPCR was done for Aspergillus fumigatus, that, and along with serum galactomannan with more than 0.5, when serum galactomannan is positive, it completely shows that there is an angioinvasion. When these 3 criteria were positive, it was associated with very high mortality, 100% mortality rate in patients of aspergillosis. So what they propose that it is not as mycological criteria are very important, because other 2 criteria are non-specific in COVID-19, the clinical criteria and the imaging criteria. So where they suggested that combination of markers like blood markers and respiratory sample examination, these should have been used for diagnosing and identifying the patients with COVID-associated pulmonary aspergillosis. And also one of the findings in this study was that the qPCR, which they had conducted, it can help in identifying false positive results when the galactomannan is once or twice positive, but not serially positive, or when the culture, especially taken from the upper respiratory tract, are positive. So qPCR can be used. So with this, I like to focus the other study where very different incidence of aspergillosis in different centers was observed. And this is one of the largest study where they have recruited 20 centers from 9 countries, and the same group which has proposed ECMM and ESHAM group, many of those investigators were there in this study. So those criteria were used, which I described earlier, and under using that criteria, 592 patients were recruited, and among these, only 2% were patients who were histologically proven for kappa were included, and majority one of them are probable kappa, like 13.5% were probable kappa, and 81% of the cases were without kappa. So this was basically a case control study, and what the participant countries, you can see majority from Europe, but also from one of the center from Pakistan. And what they observed was that kappa was diagnosed in a median of 8 days after ICU admission. And it was predominantly in older patients, and those patients specifically had some or the other form of invasive respiratory support. And also the role of ISAC inhibitor, tocilizumab, was associated with development of kappa. And although the median prevalence of kappa was 10.7%, but there were variable rates ranging from 3 to 10% in different centers. And this was also depending on the criteria used. So kappa was also associated with significantly lower 90-day ICU survival rate. And also, if you see, 57% in patients who were not diagnosed with kappa had a high 90-day ICU survival was more in patients who were not diagnosed with kappa, whereas In Kappa, only 29% of patients survive after 90 days. So all these studies clearly highlight the high morbidity and mortality associated with this pathogenic mold infection. So now quickly coming to mucormycosis. So why I'm putting up this flag of India here, just to highlight that India suffered a huge burden of mucormycosis during the time of second wave of pandemic and during the time of May to June 2021. India reported more than 45,000 cases of mucormycosis, and this captured really media attention. In the parliament, the questions were raised because so many cases of mucormycosis occurred during the Delta wave in India. Although mucormycosis was not only from India, it was reported from other countries also, which I'm going to show. So coming to mucormycosis, first I like to show that mucormycosis always existed, was always there, but it was always considered to be disease of patients who were diabetic. But it is not like that. There are several risk factors which show different clinical presentation in mucormycosis. So if patients are immunocompromised, you will generally see disseminated diseases, whereas in cases of traditional mucormycosis cases, uncontrolled diabetes, the major presentation is rhinoorbital cerebral. And also patients with hematological malignancies and transplant, most affected site is pulmonary. And also in malnutrition or premature GI mucormycosis is there. And we have also observed outbreaks of cutaneous mucormycosis in trauma as well as in burn patients. So if you see, there's a different clinical presentation depending on the risk factors. So what happened in COVID-associated mucormycosis globally? So COVID-associated mucormycosis is one of the review articles just to highlight that majority of the COVID-associated mucor, 2/3 of the cases were from India. And also Middle East reported large number of cases after India. And also very few number of cases were there from USA as well as from Europe. And majority of the cases, if you see, have comorbidities. And the majority of the comorbidities, about 65% of patients, 60% of the patients who developed mucormycosis had diabetes, which was the underlying risk factor. And also, as it was diabetes, you will see rhinoorbital cerebral mucormycosis was the most commonest presentation globally, including India. And some of the important features were that 41% of mucormycosis infections resulted in patients' death. And this is quite a substantial high mortality associated with this disease. Mucormycosis has several underlying phenomena which are occurring, which predispose individual to development of the mucormycosis, which is very well known even before the COVID outbreak. And that was mucorales iron metabolism, which plays a very crucial role. And increasing the levels of free iron in mucormycosis played a role in the development of mucormycosis in COVID-19 as well as without COVID-19. Also, steroid therapy and related immunosuppressant therapies dampened the immune response, which was underlying immune response which was seen in cases of mucormycosis. And specifically, if you look at the Indian cohort, which I'm going to discuss later, majority of the patients, even if they were not compromised, they received high doses of steroids. So that was also considered one of the factors for development of mucormycosis in India. In any case, India has a very high prevalence of diabetes. So, and also I'll show you the study where the fungus spore burden was high in India at that time. So all these factors, there was syndemy of all these combined factors which led to the outbreak of mucormycosis in India. So I chose this one particular study because this is one of the study which recruited 25 hospitals in India during the pandemic, and during the early pandemic from January to June 2021, about 1,700 confirmed cases of COVID-associated mucormycosis were analyzed, and age-matched control, about 3,900 controls were included. And these authors wanted to study whether the therapies which are used for COVID-19 have any role in the development of COVID-associated mucormycosis. So what they observed was cumulative dose of glucocorticoid was very, very significant. High dose of glucocorticoid was one of the risk factors in the development of CAM. Also, in addition, zinc supplementation, CRP was very high in these patients, and also several of the host factors which were associated. So the important host factors were diabetes mellitus as well as diabetic ketoacidosis. What else was observed was the stay in the rural area. Probably this was related to more of the exposure of the spores. So these were the important criteria which were assessed in this study. And also what they observed that surgical resection and primary antifungal therapy combined were independently associated with better odds of survival at 12 weeks. So both these things were important for the survival of the patients. And at that time, we had huge problems of non-availability of even amphotericin B. So that was a difficult time which India faced, but we went through, we really got a lot of international support, and also India actually really declared this disease as an emergency, and many centers were converted only for mucormycosis, and a lot of support from the health infrastructure, from the government was provided, and we could really took control of this disease. So also one of the important things they suggested that several treatment practices, in addition to rural residents, which I informed that they were very important host associated factor. So that say that like this study really emphasized that judicious use of COVID-19 therapy, specifically the steroids, should have been important for the control of this disease. And also one of the important factor to control mucormycosis was to have a great glycemic control to prevent COVID-associated mucormycosis. So the second study I chose because this is one of the study which, although the number of cases in this study were less, but this was a holistic study. I mean, it included also the spore burden count throughout the Delhi. It was conducting a spore count at the time of the mucormycosis outbreak. This study also had confirmed cases of COVID-associated mucormycosis by biopsy proven, and this primarily focused in the New Delhi area. So here, the COVID-associated mucormycosis 50 patients were recruited from 7 hospitals, and during the second wave, April to June. And here we also did the more spore concentrations in the outdoor air and correlated with the climatic parameters. Geoclimatic parameters were also considered in the study. We also selected some hospital formites, and we also cultured whether mucorales were there in the ICUs. And this is one of the first study where we did ITS sequencing and also whole genome sequencing to know whether these isolates were clonally related or not. Because there were several questions which were asked at that time, whether the infection is acquired from the hospital or the patients are acquiring from outside. So this was one of the preliminary study which was done. And of course, this factor, independent risk factors of CAM were similar as the bigger studies, newly diagnosed diabetes, active cancer, severe COVID-19 infections. And also the factors which were associated with reduced risk of CAM was supplemental oxygen was actually protective. And also remdesivir therapy was actually protective. And also if the patients were admitted in ICU, they had an important treatment parameters. So these were all factors which are associated with reduced risk of CAM. But the whole genome sequencing, what that showed, first of all, it showed that Rhizopus oryzae and Rhizopus delima, both were very, very important species causing this outbreak. Both were, Delmer had some problems in ITS sequencing, so which was confirmed by whole genome. And also what we observed that majority of these strains were not related. So although in one hospital clustering of the strains are there, but the SNP difference was significant. And the SNPs were not so close to support that there's ever single source or case of nosocomial transmission, suggesting that there was no clonal population. Probably these patients were acquiring the disease from their home, from their separate environment, and they were coming to the hospital. So also one of the important factor which we observed, we also counted the spore count. In our institute, we have this allergic count, spore count going on. So there we collected the data for the fungal spores. And what we observed that 3 to 4 weeks before the outbreak which happened in India, there was a high uptick of environmental spore concentrations. And that correlated with also the increasing temperature and high evaporation and decreasing humidity. So we observed that probably increasing temperature and relatively low humidity promoted the dissemination of the spores. And although the no mucorales were cultured during the time from the hospital fomites, but the outdoor environment had a high uptick of fungal spores. So this study just highlights that a more holistic approach is required whenever we are investigating an outbreak of fungal infections, because fungal infections generally acquired from outside sources. Now, coming to the third very important clinical entity, candidemia, which is
Professor Chowdhary. So just to stay on time, so perhaps if you can do this in not more than 3 minutes.
Yes. I just have 2 slides.
Yes, thank you so much.
Yeah, just last 2 slides. So just to tell you that the second important was bloodstream infections of Candida. And this is one of the study from New Jersey, just to highlight that what were the factors associated with development of COVID-19, development of candidemia in COVID-19 patients. And the etiology of the candidemia varied from different countries. Albicans was the most common in US, but I'll show you that Candida auris endemic countries had more Candida auris transmission during the time of COVID-19 ICU's admission. And here the ICU admissions stay in those patients who developed candidemia. The ICU admission was prolonged. There was a prolonged ICU stay. And also most important was mortality rates were higher in these patients as compared to the non-COVID-19 patients. So although this was the case control study, just to tell you about the surveillance study where the CDC analyzed the cohort of patients, and they found out that in non-COVID-19 candidemia, liver disease, solid organ malignancy, and prior surgery were important, whereas other risk factors in COVID-19 are similar, which I told you before. And also, if you can see, the mortality was high. So just quickly, the antifungal resistance problems which we faced during the time of COVID-19. So this just small study to show you that Candida auris, already Dr. Souha introduced, Candida auris is one of the multi-drug resistant pathogen. So when we had the early outbreak, we observed this very small study, April to July, where we observed that 67% of the cases were due to Candida auris candidemia, and 60% fatality rate was observed. So what was more important was high rate of azole resistant, multi-drug resistant to two classes or 3 classes. So Candida auris is known for this. And also when we did the high in case control study in 2 other ICUs, we again observed that in non-COVID-19 cohort and COVID-19 cohort, 2-fold increase in candidemia occurred. And these were the factors which were associated with the development of candidemia, similar as observed in previous studies. So now, just not these 3 were important. We had several reports, sporadic reports, case reports of disseminated, of isolated cases of endemic mycosis, drug-resistant trichosporon, Asahi, pneumocystis, streptococcal from all over the world. And finally, to show you very, very interesting cases that you have to be very vigilant during the time of SARS-CoV-2 this is one of the case of histoplasmosis, which we discovered in a patient which was just diagnosed because a false galactomannan was positive in this. So once the galactomannan was positive, there was no aspergillus, neither the respiratory symptoms, neither the respiratory imaging was suggestive of aspergillosis, but this patient had isolation of histoplasma capsulatum from the blood. So just to end that, we have to be vigilant of several infections caused by fungi, which are difficult to treat, which cause high morbidity and mortality. Thank you very much.
Thank you very much, Professor Chowdhary, for this excellent overview on fungal infections in the ICU post-COVID-19. As I mentioned at the beginning, please, for the attendees, if you'd like to send your questions via the chat, we'll try to answer as many as we can. And it's now my great pleasure to introduce the next speaker, and that's Professor Alex Soriano. Professor Soriano is an expert in the field of bacterial infections, not only gram-negative, but also gram-positive. However, he will concentrate this talk on gram-negative superinfections. Professor Soriano is a consultant of infectious diseases in the Infectious Disease Department of the Clinical and Provincial Hospital of Barcelona in Spain. His main research interest is in severe infections by both gram-positive and gram-negative, as well as the diagnosis and treatment of foreign body infections, particular interest in prosthetic joint infections. Professor Soriano is currently the Vice President of the European Bone and Joint Infection Society. He's also the co-editor-in-chief of Infectious Diseases and Therapy. Professor Soriano, the microphone is yours.
Many thanks, Souha, for the introduction and in order to go through the time that is tight. My task is to discuss about gram-negative superinfections. These are my disclosures, and particularly during the respiratory viruses outbreaks, we know that there are several factors that influence the increase in the risk of superinfections by gram-negatives, and particularly multi-drug resistant gram-negatives. And these factors are particularly the care disorganization, particularly in the management of devices, catheters, etc., probably because of the overwhelmed workload that these aspects are not very well cared, and this is important, and it has a clear impact on the infection rate. Secondly, because there is an increase in the number of patients in the ICU, but particularly under mechanical ventilation. And this is, of course, a risk for having more ventilator-associated pneumonia with all the problems, but particularly during the respiratory viral infections outbreaks, we know that there is an increase in the prescription for suspected co-bacterial infection, that the prescription of antibiotics, and definitely, as we will discuss now today, this is a very critical factor for having particularly multi-drug resistant gram-negatives. In the other side, there are several aspects that indeed reduces the risk of having this kind of infections, particularly the hand hygiene promotion and the various precautions that are spread during this period. And for this reason, we can see in the literature some data suggesting that there is a decrease in the infection rate, and others that clearly shows an increase in the particularly the super bacterial infections during the admission. This is the data, and it's close to many other data that you can see in the literature. This is from my hospital, where we observe in almost 1,000 patients with COVID in my institution, with the indeed, as Souha has mentioned in the introduction, the co-bacterial infection during COVID. I mean, at the moment the patient is admitted to the hospital, co-bacterial infections with pneumococcus, with Staph aureus, or other pathogens is relatively low, maybe less than with influenza infection, about 2%. These varies between 2 and 8% in different scenarios, and the superinfections, those infections that appear after at least 48 hours admitted into the hospital, where we can observe is that in general words, it's not so high, but what it's evident is that this significantly increases among those patients that are admitted in the ICU, and particularly this refers to ventilator-associated pneumonia and catheter-related bacteremia. At least these are the data from my institution, and in many others match it more or less the same. And what we observe is that Staph aureus definitely play a role, but also gram-negatives, and particularly non-fermenters like Pseudomonas aeruginosa, Stenotrophomonas maltophilia, and of course Enterobacterales, particularly with Klebsiella, are dominating this area. And of course, in those areas where the prevalence of resistance is high, this is associated with multi-drug resistant pathogens in these infections. And for this reason, I wanted to review which are the major steps for the acquisition, the colonization of multi-drug resistant pathogens. And in order to simplify this concept, I will review these three major steps. The first one, of course, is the exposure. The patients are exposed, particularly when they are admitted in a hospital, in acute care center, where the prevalence of these pathogens is relatively high. We can consider high, for example, more than 20% in Klebsiella and Pseudomonas, for example, or also, of course, a prior exposure in these acute care centers in the past 3 months, particularly, and also finally, and it's very critical, the admission, the previous admission in a long-term care facilities. There are places where the characteristics of the patients, of course, are associated with a high prevalence of multi-drug resistant pathogens, multi-drug resistant gram-negatives. But also it's important that the exposure is clearly associated with the number of invasive procedures. When the patient has several catheters, had a orotracheal tube, had urine tubes, etc., requires a constant contact with the healthcare workers. And of course, the number of times you are touched by the healthcare workers, you have a higher risk of becoming colonized by these pathogens. Yeah, particularly for gram-negatives, this means the colonization of the gut that we will come back afterwards. But how we measure the pressure, the exposure, and the risk of becoming infected? Well, here it's interesting to know, which is the concept of colonization pressure. That is the number of patients colonized at a specific moment divided by the total number of patients in the unit. Imagine this is a unit with these 12 patients, 12 beds, and the number one, for example, day one, we have, for example, 4 patients that are colonized by these multi-drug resistant pathogens. So the colonization pressure at these specific days is 0.33, 4 out of 12. Then maybe the day 2, we have 6 patients out of 12. This means that the colonization pressure is 0.50. The number 3 is exactly the same, but the number 4, maybe 1 patient died or maybe 1 patient was discharged, and then the colonization pressure at this specific day was 0.41. Yeah. So the average after several days in the ICU of this colonization pressure, we know in a paper that we published several years ago in Critical Care, we know that when the colonization pressure is higher than 0.43, this is an independent predictor of being colonized, of acquiring Pseudomonas aeruginosa. So this is important. And remember that this was evaluated under the standard contact precaution measures that we apply in our institution as in many others. So we can measure this pressure of in a specific unit for a specific pathogen. But it's not only to be exposed the risk factors, because all the doctors, we are working in the ICU, and of course we are not finally colonized, which are the main factor that favors the colonization. Well, the main factor is the colonization immunity. What is this concept? The second concept I wanted to discuss today. The colonization immunity is mainly the gut microbiota. As you know, our microbiota, it's more than 300 different species and more than 10 to the 11 bacterial cells, bacterial and many other pathogens, but particularly bacterial cells per gram of feces. And of course, it's very difficult to detail in terms of a species. And for this reason, we aggregate here in different phylums. There are 35 phylums that concentrate of the different species, bacterial species. And we know that there are mainly 5 phylums that are representing our gut microbiota. And indeed, the majority of them are Firmicutes, Bacteroidetes, Proteobacteria, Verrucomicrobia, or Actinobacteria. And we know that they play a very important functions, particularly metabolic functions, but also trophic functions in terms of proliferation of the epithelial cells, but also in the homeostasis of the immune systems. But what is important for us today is the important protective protection that they represent to avoid the colonization by different pathogens, particularly multi-drug resistant pathogens. So this barrier effect is critical. So in a healthy person, even if we are exposed to these multi-drug resistant pathogens, of course, these pathogens are not colonizing our microbiota. And for this reason, we talk here about colonization immunity. However, if the patient is exposed to an aggression and we decrease this predominant microbiota, this, of course, opens a hole that can be now be occupied by multi-drug resistant pathogens. And of course, once here, these pathogens are able to transfer the mobile genetic elements, particularly plasmids, and so to transfer the resistant determinants among the other bacteria present in the microbiota, and also is a potential for invasiveness that we will discuss afterwards. And which is the major aggression? Definitely is the antibiotic consumption. The prior exposure to antibiotics for more than 3 days in the past 3 months, we know it's the most important factor for being colonized, after being exposed to be colonized by multi-drug resistant pathogens. But it's not the only one. Fragile patients, particularly aging, and also high Charlson scores are associated with a worse microbiota, and so favoring the colonization, but also acute stress and chemo and radiotherapy also predispose to colonization. But finally, it's not only the colonization and the factor that it's more clearly associated with a definitive infection by these pathogens is when the aggression persists during the time. And these, of course, favor the massive expansion of these multi-drug resistant pathogens in the gut. And from here, it will become a high risk for infection. This is the process that we know as a selection and amplification of the multi-drug resistant pathogens in the gut microbiota. And this process can occur just in 3 to 5 days after colonization if the patient is particularly exposed to a broad spectrum antibiotic treatment. And of course, the gut colonization is the major risk factor for being infected afterwards by a multi-drug resistant pathogen, infected, for example, urinary tract infections, ulcers that become infected, but also pneumonia or catheter-related infections. From here, this is very important because what we learn from several papers is that the risk of having ventilator-associated pneumonia by an ESBL enterobacterial, for example, is very low. It's very low if the patient is not colonized by this pathogen. All these papers show how high is the negative predictive value, more than 99% here, for example, more than 93% in this second paper, or here, for example, more than 97% negative predictive value. So it could be very helpful to identify those patients that do not require the coverage of these multi-drug resistant pathogens. Yeah? If they are not present in the gut, probably we can be quite sure that this patient is not infected by this pathogen. And this also, we have data for Pseudomonas aeruginosa, here considering not only the rectal colonization, but also the pharynx colonization in the ICU and the ventilator-associated pneumonia. And again, those patients that were not colonized, the risk of being infected by this pathogen is very low, with a negative predictive value higher than 95%. So this is important to select or how to do some antimicrobial stewardship programs in order to reduce the exposure to broad spectrum antibiotics. Indeed, if we look at the recent data from the clinical trials that were performed in nosocomial pneumonia, and particularly in HAP-BAP infections, for example, the papers that compare meropenem with ceftazidime avibactam, or with ceftolozane, or with imipenem relebactam, or with alcohol, what we observe is that nowadays Klebsiella pneumoniae is the leading pathogen. In all of these trials was the most common one and quite frequently associated with SVL production, but year by year increasing the number of carbapenemase producing Klebsiella. The second most pathogen, of course, is still Pseudomonas aeruginosa, with resistant rates to the major beta-lactams, carbapenems, increasing more than 15-20% in many centers. Of course, in general, in Enterobacterales and Acinetobacter baumannii, a little bit less, and it's more focused and specific in some regions, centers, countries, etc. So year by year, more close related with specific areas. But it's evident that when we address how to treat these multi-drug resistant pathogens, one issue that it's very important for any severe infection, this is recently published data on bacteremia, but we have data also in nosocomial pneumonia, that the empirical antibiotic treatment, it's very important in the outcome of my patient. This paper that analyzed more than 30,000 episodes of bacteremia by gram-negatives, but also gram-positives and candida species, what they observe is that after adjusting for so many variables that are critical, that are important in the final outcome of my patient, the mortality, the patients that receive active antibiotic therapy from the beginning, and this means within the first 24 hours from obtaining the blood culture, had a significantly decrease in the mortality rate. So we need to select adequately the antibiotic treatment. However, how to do this in the era of the multi-drug resistance? I mean, with more than 20% of ESVL, multi-drug resistant Pseudomonas, or even carbapenemase resistant in some regions. How to do that and how to offer our patient the best option. Of course, rapid microbiological tests are very important. This is just some data in HAB-BAP patients and also community-acquired patients in these 79 critically ill patients where the alphas performed PCR in comparison to culture. And we observed that there was a 40% agreement, but there was also, even in 50% of the cases, an improve in the diagnosis using the PCR-based techniques in comparison to cultures. And particularly this was associated with the more identification of Acinetobacter, E. coli, Haemophilus, Staph aureus, or Pseudomonas, so important pathogens that are associated with the development of pneumonia. So definitely what the authors observe, and this is interesting, is that by using the syndromic PCR, they were able to significantly shorten the time to having a microbiological identification, 3 hours when they combine culture and PCR techniques, and by culture only, they last about 72 hours to obtain as a mean time to obtain a definitive diagnostics. And also it has the implementation of these techniques, it has an impact in the antibiotic consumption. As you can see here, for example, in meropenem, there was a significant decrease in the total consumption after the implementation of the PCR techniques. The problem is that, of course, they are not so cheap, and it's important to increase its evaluation and particularly also the outcomes, not only the identification, but also the outcomes of these patients in order to implement these techniques. But of course, it will take some time. Which are the other alternatives where we don't have these techniques? Well, this is something that we proposed a couple of years ago, that when we start a patient that is in an environment where the prevalence of multi-drug resistance is high, that develop a nosocomial infection, so at risk of having an infection by these pathogens, even respiratory, abdominal, urinary, catheter, surgical wound infections, of course, we need to start with a broad spectrum antibiotic covering the majority of the pathogens, including gram-negatives and gram-positives. And we can do that by using the new beta-lactams, beta-lactams associated with beta-lactam inhibitors, or a combination including amikacin or colistin, applies an anti-staphylococcal agent, and even metronidazole in some ways, if we are, for example, using this strategy. And even in some particular areas, of course, we have to be remind maybe Stenotrophomonas or Acinetobacter, if in your region is high, or metallobeta-lactamases, that of course it will change this broad spectrum concept. But in the end, what we do is, okay, we start with a broad spectrum antibiotic, and of course we obtain clinical samples. This is critical. What happens sometimes is that for whatever the reason, the samples could not be obtained, or maybe were negative because the antibiotic treatment was started after taking the samples. For whatever the reason, the samples are negative. And what we recommend here is that to test the colonization status of my patient in whom we start a very broad spectrum antibiotic treatment from the beginning. This means a rectal swab and an oropharyngeal swab, and of course respiratory secretions, of course, as clinical samples. But this is very helpful because after 24, 48 hours, not that much, the patient is more stable. The patient, if we started with an adequate antibiotic from the beginning, we implement all the measures to stabilize the renal function, the blood pressure, etc. So my patient now, it's much better. And from here, once we obtain the clinical samples, if these are positives, disregarding the rectal swab, of course, we have to adjust the antimicrobial therapy to the antibiogram of the clinical samples. And so the broad spectrum antibiotic that we have started now can be significantly shortened in targeting the clinical samples. But if not, and this is a problem in so many occasions, then is at that point when we look at the rectal swabs and the oropharyngeal swabs, and if the patient is colonized by some pathogens, then probably we have to maintain the coverage for third generation cephalosporin resistant Enterobacterales, for example, or if the patient is colonized by carbapenemase resistant Enterobacterales, or if the patient is colonized by Pseudomonas, and the clinical samples are negative, probably we have to focus on these pathogens. But if the patient is not colonized at the acute phase by one of these pathogens, then we can move down and we can remove the broad spectrum antibiotic and to focus on the more susceptible using third generation cephalosporins for these patients. The same for Staph aureus and even the same for echinocandins. But the second, and with this I'm going entering in my two final slides, one of the second most important things, the first is how to select from the beginning the best antibiotic for my patient in order to increase the survival rate. But the second is how to de-escalate as soon as possible. First, using, of course, the clinical samples. Second, using the rectal and the pharynx swabs. And the third is how to shortening the antimicrobial treatment. And this is just a very recent analysis in the duration of antibiotic treatment for ventilator-associated pneumonia. That is something that is under debate. And as you can see here, no difference in terms of mortality for 7 days or more than 10 days of antibiotic treatment in BAP. No difference in mortality, not even in global for any pathogen, not specifically for non-fermenting gram negatives. And it's true that, again, in this meta-analysis, it has been observed that when we evaluate the recurrence rate, this is a little bit much higher among those patients that receive for non-fermentative gram-negative BAP. They had a significantly higher rate of relapse, of recurrence. But it's true that these papers also, it's clear that there is a bias of follow-up, because those patients that receive a shorter duration therapy had a longer period without antibiotics that were follow-up, and this was not the case for those patients that received double the duration of treatment. So still we need more data on this topic, but probably my feeling is that for multi-drug resistant gram-negatives and non-fermentative, particularly Pseudomonas, Stenotrophomonas, probably we need to combine the systemic therapy with a short period of time, 7 days, but also associated with inhalation therapy. This is under debate also, but my feeling is that by doing so, maybe we will decrease also the recurrence rate associated with a systemic antibiotic treatment. This is just if someone is interested to have this pocket guide is updated every week, you can send me an email if you want, and I will bring you a free test, just you to check it. And the conclusions, of course, can take it by yourself. This is just some of my conclusions, but in order to be on time, I think it's much better to stop here. Thank you, Souha. Thank you for your attention.
Thank you very much, Professor Soriano. This was an excellent overview of the topic, and I'm sure you raised very important issues that can be applied with the spirit of stewardship, in the ICU, where a lot of antibiotics are used haphazard and aggressively. We have we have few minutes to answer some of the questions. I think Professor Chowdhary and Van Sorge have already addressed some of the questions on the chat. I see that. Just a question for Professor Van Sorge. We know that with the emergence of group A strep that you very eloquently covered in terms of why we're seeing more of that, do we need to be screening close contacts before, applying, giving them therapy? Should we be screening household or schoolmates in areas where we diagnosed an invasive group A strep infection?
If you do the screening, you're probably too late in starting your prophylaxis, because you need to do it in a very timely manner. There's only a short window where it still makes a difference. So I don't think there's time to screen and get the results before you start treating. Okay. What we have seen from our preliminary data, and that is something that is worth sharing, I think, is since we looked at secondary attack rate in a household context before and after our change in the prophylaxis guidelines, and we do see a decrease in the secondary attack rate. So that is, it seems to have worked in at least bringing down these case numbers, but we don't screen beforehand. So everything is done within 24 hours. Okay,
thank you very much. Professor Chowdhary, there was a question related to do we need to be giving prophylaxis to the very high-risk patients, whether following COVID or influenza, those who have received steroids or poorly controlled diabetes? What are your views on prophylaxis, particularly as we're thinking now more and more of antifungal stewardship? Like, where do you position the need for prophylaxis?
So not much data is available, the role of prophylaxis in especially in kappa, but whatever data is available, the median time for development of kappa is very short, between 3 to 5 days. So once these patients are admitted, they're either already colonized or they develop colonization. And that short median time does not give you an opportunity for starting the prophylaxis. So that's what specifically for kappa studies available.
Okay, great. Thank you very much. And so Professor Soriano, I think you raise a very important point about, screening. So I'm assuming that it's something that you do on a routine basis for your ICU admissions. So you screen your patients, and then once they develop an infection, you try to decide on therapy. And I think this is an area that really needs to be more encouraged with the spirit of stewardship. So one of the questions raised by the attendees is, what are your thoughts on the use of probiotics to reduce multi-drug resistant organisms, particularly carbapenem-resistant Enterobacterialis?
Well, to be honest, in terms of probiotics and the ability of probiotics to decolonize a patient with a multi-drug resistant pathogen, the data it's not supporting it. But there is still ongoing several studies that are trying to evaluate the ability of fecal microbiota transplant, with some data still quite preliminary, and we are indeed doing in my department a study that is comparing fecal microbiota transplant versus one probiotic that contains several species. Because to be honest, in my opinion, if you use only one bacteria, one probiotic with a single bacteria, for me it's very difficult. Maybe a combination of different probiotics, different bacteria species. It's a possibility. The trial is ongoing. We compare standard of care, a fecal microbiota transplant, and probiotics, and we will see, because it takes time. But it's something to develop in the future, how to decolonize, and which is the role of probiotics, mixed probiotics, fecal microbiota transplant, or even specific products developed for a specific pathogens. This is a really evolving world and very interesting.
Thank you very much. A question for Professor Nina. So as you know, we don't do molecular typing in a lot of low middle income countries, but I tell you from just witnessing what's happening in Lebanon, for example, but also from talking to colleagues from neighboring countries, they're seeing a lot more group A strep invasive disease. Do you think the M1 UK strain has really spread globally and we're just not reporting it because we're not typing our strains? Yeah,
it's highly likely. Because I mean, even it reached even Australia, so it seems to have spread globally. It seems to be a very successful strain.
Yeah, so perhaps we need to talk to international organizations. Perhaps they can work on something to try to collect isolates from from low middle income countries.
Right. This is very important, I think, to just get a better view on how big the problem is and how aggressive this strain is across the globe. So, yes, that would be very important.
And the last question to Professor Chowdhary, there is a question by one of the attendees. So they're asking about the diagnosis of kappa can be very challenging because physicians are not too keen at doing bronchoscopy. So how do we get, you talked about the ECMM, ESHAM guidelines, but in your practice, like what would be your advice for how to tackle this?
Yeah, so of course it's not, I just, discussed this, that it is not possible. Those traditional diagnostic criteria of taking the lung biopsy is not possible. So that is why it is important to have the biomarkers, the quantitative PCR for specific Aspergillus fumigatus, galactomannan. These are the assets for diagnosing invasive aspergillosis in clinically suspected cases when you have imaging studies which shows atypical cavitation, infiltrates, although these are also very specific for COVID-19, but these are the patients whose fever is not resolving. So these are the patients who have to screen repeatedly for serum galactomannan, which is more than 0.5, which shows that there's an angio invasion. And then you also have to repeatedly from respiratory culture, if you are using, then you have to have a repeated isolation. Not one single isolation will say that this is, single isolation can be just by chance contamination. So that is why I said it's really challenging, but all these criteria and a strong clinical suspicion will really help you in making diagnosis.
Yeah, and I said the last question, but I'm just gonna profit from the fact that Dr. Soriano is with us for this last question. So even for Pseudomonas ventilator-associated pneumonia, if you combine systemic therapy with inhaled, you would be satisfied with 7 days of therapy?
Yeah, this is something that require, in terms of the success rate, in terms of mortality, it's clear that 7 days apparently it's equal. The thing is that to eradicate Pseudomonas from the Pseudomonas and other non-fermentative from the sputum, it's more difficult. And so my feeling is that we need to increase our experience. But my feeling And what we do is to do 7 days and to combine with inhalation therapy.
All right. Well, thank you very much. I think we bring this webinar to a conclusion. I very much would like to thank our outstanding speakers, Professor Nina Van Sorge, Professor Anuradha Chowdhary, and Professor Alex Soriano. Thank you for being with us. Thank you, Fee Johnston, for organizing this webinar. The attendees will receive certificates for attendance, and those who registered and could not attend will be able to watch the taped version of this webinar. Thank you very much for being with us, and hope to see you in person very soon. Thank you.